eventual phones are the chat box, and for questions, please use the questions box. Tonight's webinar is Dr. Chamika Sinanayake. Dr. Chamika is a medical officer. He is undergoing training for medical doctors in health informatics at the Postgraduate Institute of Medicine, University of Colombo, while in service within the Ministry of Health, Nutrition, and Indigenous Medicine of Sri Lanka. Dr. Chamika graduated from Tianjin Medical University. He obtained his master's in biomedical informatics at Postgraduate Institute of Medicine, University of Colombo. During his postgraduate studies, he was involved in the Phase 1 pilot project, implementation of Smart VA in Sri Lanka, a subcomponent of improving CRVS by Bloomberg Data for Health initiative. Dr. Chamika also worked as a fellow researcher at Melbourne School of Population Health and Global Burden of Diseases, University of Melbourne.
Hello?
Yes, Dr. Chamika, we can hear you.
Okay, hi. Yeah, hello everyone. Thank you for joining me at the AHIN Arbor OpenIMIS forum. Today I'll be talking about the health system of Sri Lanka and the emerging role of health insurance. All of you must be wondering what this picture is about. This picture shows an ancient medicine bath made out of stone centuries ago in Sri Lanka. The history of medicine in Sri Lanka has been fashioned over the centuries by a synthesis of several unique intrinsic and extrinsic factors. The history of medicine in Sri Lanka can be divided into major historical periods in its rule, such as ancient medical practices, medicine under Sri Lanka kings, Portuguese period, Dutch period. In the early phase of British period, a new phase was born with the creation of a separate civil medical department in 1858, by which medical facilities were provided to the civilians by their department free of military control. So today, our outline would be demographics of Sri Lanka and a basic overview of health system of Sri Lanka and the health insurance status of Sri Lanka. Demographics of Sri Lanka. Apart from the demographic information shown here, administratively, we have 9 provinces, 25 districts, 331 divisional secretariat divisions, and 14,021 Gramanildara divisions, which are the village units of Sri Lanka. Regarding key economical indicators, the sectoral composition of GDP, we have 7.7% from agriculture and 26.1% from industry, 57.7% from services, and 9.2% from taxes, essential subsidies on products. Currently, due to increased proportion of taxes, there is an increasing trend of people investing through insurance through customized packages. Gross domestic production of Sri Lanka grew about 3.2% in 2018 compared to the last year. This rate is 1/10 of 1% less than the figure of 3.3% published in 2017. The GDP in 2018 was 88 billion US dollars. Sri Lanka is number 66 in the ranking of GDP among of the 196 countries that was published. So let's talk about a bit about social economic status over time. As you can see, the population has been rising over the past few years in millions, but the population growth has been at a steady phase over the past few years. When we talk about selected macroeconomic indicators, the GDP has been, over the past few years, it has been at a steady phase, but it's slow compared to the 2014 and 15. The money supply is, there's a trend of reducing during the past 2 years with the inflation as well, and the unemployment rate has been at a steady phase all throughout the few years. And domestic expenditure and savings. You can see over the past 2 years, the consumption has been increased and the investment and domestic savings has been reducing trend, which leads to a negative savings investment gap as well. Talking about social indicators, we have a literacy rate of 92.6%, and the computer literacy rate of 27.5%, and majority of the ethnic groups according to 2012 estimates are majority are Sinhalese. So let's compare us with the world trends. As you can see, the world GDP growth in selected regions, we are about less than 1% less than the world trend. And also regarding the literacy rate and the life expectancy, according to 2016 data, we are correlate with the at the satisfactory levels with our neighboring countries. Let's talk briefly about the healthcare system of Sri Lanka. Being a low middle income country till very recently, Sri Lanka has boasted achievement and maintenance of comparatively good health indicators with minimal resources. As you can see, we have achieved the neonatal mortality rate of 6.5 per thousand live births, maternal mortality rate of 39.3 per 100,000 live births, and percentage of institutional deliveries are about 99.9%. So all these achievements with a total health expenditure of 218 billion Sri Lankan rupees, which represents a very low allocation as 1.5% of GDP. This has portrayed the workforce. It portrays the skillfulness and the commitment towards the healthcare delivery within the country by the healthcare workforce. Let's talk about the healthcare expenditure. The level of current health expenditure expressed as a percentage of GDP. Estimates of current health expenditures include healthcare goods and services consumed during each year. This indicator does not include capital health expenditures such as buildings, machinery, IT, and stocks and of vaccines for emergency or outbreaks. And also there are different types of medicine practiced in Sri Lanka, such as primarily it's Western medicine, which is regulated by the Sri Lanka Medical Council, and also traditional single medicine, Ayurveda, Siddha, Unani, which is regulated by the Sri Lanka Ayurvedic Council, and also Sri Lanka Homeopathic Council regulating the homeopathy practice. Healthcare at a glance, we have public sector and private sector. At the public sector, on the top levels, we have tertiary care hospital and his specialized hospital and specialized programs and secondary hospitals. At the lower level of the organizational hierarchy, we have preventive and curative system divided. So preventive system include medical officer of health officers, field clinic centers, and well women's clinic, antenatal clinics, it goes so on. In the curative system, we have mainly deal with the provincial councils, which includes divisional hospitals, primary care units, healthy lifestyle centers, etc. And the private sector also takes a bulk of the healthcare service delivery in Sri Lanka. For all this health care system to exist, there should be always a monitoring mechanism. So there at the apex, we have the Ministry of Health, and which is oversighted by the Sri Lanka Medical Council, University Grant Commission, and the Postgraduate Institute of Medicine, which look after the knowledge. And there's Cosmetic Devices and Drug Association, which regulates the pharmacy and devices, and provincial councils and local governments, which regulates the public hospitals, laboratories, and dispensaries. And regarding the private sector, it's mainly regulated by the Private Health Services Regulatory Commissions. And mainly majority funded by private sector, mostly from out-of-pocket expenditure, employers, insurance, not-for-profit, and other. And the public sector, the main funds are from general taxation revenue, provincial councils, and local government. Regarding institutional structure of Ministry of Health, we have curative services. That means all the hospitals included, all different types of hospitals. Then also we have 9 disease control programs such as anti-filariasis, anti-malaria, and HIV/AIDS, and also health promotion and protection, for which includes most of the public health institutions such as epidemiology unit, health education and promotion, and other units such as human resource development research institutes. Then all these sectors are, integrated with the indigenous medical sector as well. When you talk about the Ministry of Health, it has a very defined organization structure at the top level of ministers and health secretaries, and there's a key person who is the Director General of Health Service. Under him, there are a lot of Deputy Director General Services, which addresses healthcare service sectors such as public health services, administration, logistics, laboratory services, planning, etc. And correlated with the line ministry, there's always a provincial setup as well, and each provincial council units coexist well and works independently to address healthcare needs of the respective units. So let's talk about the curative institutional profile of curative health sector. Up to the date of 2019, January 1st, we have a total healthcare institution of 1,121 hospitals with a bed strength of 76,587. So all these health institution healthcare services are given free of charge. Challenges include a little bit of quality, timeliness of medical services being delivered. Therefore, we can assume there is a less requirement for healthcare insurance in the public sector. And also, there is a proposed shared care cluster model for curative service delivery, which coming up. In the primary healthcare development project, one of the key areas that are addressed included in development and integration of health information systems with interoperability through electronic health records as well. So let's talk about few key success stories of the public health of Sri Lanka. Sri Lanka has achieved a major public health milestone in 2016 and received the WHO certification for elimination of lymphatic filariasis as a public health problem. And malaria has caused a death and devastation in Sri Lanka of centuries. After a prolonged battle, the country has now, Sri Lanka received the certification from WHO in September 2016 for achieving malaria elimination and entered the prevention of reintroduction phase. In response to growing threat of non-communicable diseases, Sri Lanka employs innovative approaches to prevent and treat NCDs through healthy lifestyle centers. In response, Sri Lanka has invested in a robust public health system which ensures access to free health care for the population. This investment has resulted in dramatic reduction of maternal mortality and other public health gains. Sri Lanka has been an early adopter of strong tobacco control measures. The Supreme Court ruled in favor of the introduction of strong new anti-tobacco legislation, which mandated pictorial warnings to cover 80% of cigarette packets. Smoking is now banned in all public institutions in Sri Lanka, including government departments, offices, schools, hospitals, hotels, and restaurants. In wake of the 2004 Indian Ocean tsunami, Sri Lanka implemented key strategies to strengthen the emergency preparedness and response capacity of the health sector, achieving remarkable gains at policy implementation at field level. Sri Lanka serves as a model for mental health care due to its transformation of mental health care over the past decade. And Sri Lanka is the fourth country in the WHO Sierra region to eliminate measles and control rubella. And recently, we have achieved zero transmission of HIV from mother to child. Let's talk about the health financing flow. Healthcare in Sri Lanka is provided by the government, private sector, and to the limited extent by the non-profit sector. The government sector is predominantly financed from the general revenue taxation, while private sector financing through out-of-pocket spending, private insurances, enterprise direct payments, insurance paid for by enterprises direct payments, insurance paid for by enterprises, and contribution from non-profit organizations. Donor funding is largely channeled through the government sector and in certain instances through non-profit organizations. The government sector comprises of central government, the provincial councils, the local governments consisting of municipal councils, urban councils, and Pradeshya Sabhas. The central government provides budgetary funding to the Ministry of Health, which delivers service directly through its own programs and hospitals that are under the purview of the ministry. Some of the central programs also support and operate through the programs administered by the lower levels of government. The bulk of donor funding is channeled through the Treasury, while some donor funds are dispersed directly through the relevant programs or projects. So who pay for this? Majority is from private sector, 54%, and 46% from public according to 2015. But there's an increasing trend of percentage rising in from the public expenditure, and it was spent on about 38 majority in inpatients, for then 21% for outpatients, then 20% for pharmacy, sales and medicine, 5% for public health programs and other. And regarding the current spending on health, for inpatient care, we spend about 38%, 21% for outpatient care, 24% for medical goods dispensed out to outpatients, and 5% for preventive care, and 4% for governance, health system, and financing administration. From this graph, you can see how the total values of total expenditure on health and current expenditure, capital expenditure, imports of medical and pharmaceutical products by the government and private sector has been evolved through the time. So I would like to talk about I'd like to make special emphasis on the Digital Health Forum of Sri Lanka. Currently, there are many health information projects going on. So with blooming of all the health information system, there's a digital health ecosystem developed. So especially at the bottom level, we have preventive health, which covers maternal child health, nutrition, TB, chest diseases, HIV/AIDS, malaria, and non-communicable diseases. On top of that, for the large hospitals, there's a health information system which is being rolled out. It's called Health Information Management System, and for small hospitals, it's called Hospital Health Information Management System. And also, at the moment, the ministry is on the process of developing a personal health record for each and every patient, and all the patients' records can be integrated from institution to institution by master patient index with a unique identifier, which means of personal health number. Finally, all this data at the ground level flows onto the top as health statistics. At the moment, we have a very good IMMR system, which contains about 30 million records at the moment. So all this ecosystem is mainly governed by national e-health guidelines and standards. So altogether, it's called the digital health ecosystem. So let's talk about the health insurance status of Sri Lanka. As per Insurance Regulatory Commission of Sri Lanka, IRCSL, 28 insurance companies were operating in the country. Under the Section 53 of Regulation of Insurance Industry, Act No. 3 of 2011, it was made compulsory to segregate composite insurance companies into two different categories of insurance in 2015. So almost all the composite insurance companies have them segregated into general insurance and life insurance. So we have about 30 life insurance companies, 13 general insurance companies, and 2 composite insurance companies. So all these insurance companies belongs to the private sector. And for state sector, we also have an entity called National Insurance Trust Fund, which I'll be talking about in a bit later. So let's talk about the resources. According to 2017 data, we have about 448,000 agents, 18,000 employees, and 2,000 branches for delivery of insurance services. So all these insurance entities are regulated by the IRCSL Insurance Regulation Commission of Sri Lanka. It safeguards the policyholders through supervisory control of insurance companies. It is under the Ministry of Finance, and the professionals with experience at the IRCSL advise the government on policy and laws that would make the industry remain viable, able to meet its commitments to policyholders by helping them to overcome risk. And also, there's another entity called Insurance Association of Sri Lanka, which was established in 1989 under the act by the Parliament. The Executive Committee of IASL, which comprises of CEOs of all the insurance companies, are responsible for overall management of activities and is assisted by the following committees such as Life Insurance Forums, General Insurance Forums, HR Subcommittee, Actuary Subcommittee, and so on. And also, there's another entity called Sri Lanka Insurance Ombudsman Scheme. Its objective is to satisfactory settlement of complaints or disputes that policyholders of insurance companies may have against the company that sold them the insurance policy. This is the officer with whom the insurance ombudsman lies with to mediate or settle any dispute submitted to him by dissatisfied policyholders. And within this entire network, there's one overarching body, which it's called the Sri Lanka Insurance Institute. It was established in 1982. It's a non-profit making organization whose main objective is to develop the skills and knowledge of persons who are in the insurance business. And funding for SL Insurance of Institute is through the contributions made by insurers and annual subscription from its members. Sri Lanka Insurance Institute is affiliated to the Chartered Insurance Institute of London and administers examinations. So let's talk about a little bit about National Insurance Trust Fund. NITF is a government-owned only company which offers reinsurance in the country. It was formed by a NITF Act by the Parliament. Under NITF, they provide the largest medical insurance scheme, Agrahara, to uplift the living standards of public service and provincial public service and their families. It's a compulsory scheme for all the government employees at a pensionable age. The membership currently includes about approximately 900,000 government employees and their beneficiaries. Previously, their benefits were low due to low premium. Now, they have given membership options which enables them to provide more benefits for those who seek for it. It is an independent body which has been formed through a Parliament Act. Now it is under the Finance Ministry and regulation by IRCSL. Its funding mainly comes from the Treasury through government securities, bonds. Currently, it's at a profitable stage, which has made it among the top 10 state-owned enterprises. Let's talk about the insurance penetration of Sri Lanka. Penetration of insurance of Sri Lanka stood at 1.224% as of end of 2017, which is significantly low compared to other peer countries. The demand for insurance is mainly dependent on the level of disposable income of the general public. Due to the Sri Lanka's low disposable income level, the desire to invest in a life-term insurance policy has never been prevalent among the locals. However, with changes of the country's demographic factors as aging population, the government of Sri Lanka may need to initiate measures to promote awareness of life insurance policies as an alternative to increasing social security cost burden. In this graph, the S-curve demonstrates the interrelationship between per capita income of the country and the extent of its insurance penetration. Sri Lanka is currently ranked at a considerably low position in the S-curve due to low levels of disposable income and macro and industry-specific factors. And we have to talk about why there's a low insurance penetration. Sri Lanka's low levels of disposable income remains one of the key reasons for low levels of insurance penetration of the country. This situation is further exacerbated by in short term due to considerable depreciation of the Sri Lankan rupee, thus notably increasing of the cost of living of the country. The industry has been made particularly unattractive for the investors due to rising interest rates, driving investors for option for sectors beyond the insurance, as well as increased claims due to bad weather and other phenomena. Such conditions have influenced insurers to raise rates, thus further degrading the overall attractiveness of the industry. These conditions have led industry players to consider increased use of technology to reduce costs, product innovation, and optimization of the use of underutilized distribution channels to gain an edge over competition. The need for the hour is to inform and educate the general public on the importance of insurance while developing the supply chains. So the opportunities of OpenIMIS implementation, what have we achieved so far? So initially what we have done was we have obtained consensus from Insurance Association of Sri Lanka and the Sri Lanka Insurance of Institutes in their general life forums. So far we have got a positive response from them. So we are awaiting for the grant of approval from the Insurance Regulatory Commission of Sri Lanka. And with regard for opportunities for OpenIMI's implementation, opportunities. Major attention from government is currently towards the primary healthcare development project, which includes improving digital health infrastructure for state healthcare institutions, implementation of electronic health records, implementation of personal health number and the master patient index, and they are trying their best to minimize the out-of-pocket expenditure by the patients while attaining the universal health care, and also it correlately it affluence the maturing digital health ecosystem, and there's a strong academic commitment towards the digital health innovation, such as, for example, Postgraduate Institute of Medicine, which is under the University of Colombo, offers master's degree in biomedical informatics and the MD degree in health informatics, which will produce board certified specialists in health informatics section. And also there's a very strong IT support from the private sector, and more research opportunities are there regarding health financing. And regarding the insurance companies, there's a increasing trend of insurance companies being interested in healthcare data utilization, and there's an increasing need for prevention of unfair fake claims by optimizing claim review processing as well. And there's also we can see a very increasing trend of public utilizing customized insurance packages as a mode of investment. So I think that will be all for today, and thank you so much for listening. And I would like to convey my appreciation towards Professor Vajira Disanayake, Dr. Roshan Hewapatirina, Mr. Chandana Devgapitya from Sri Lanka Insurance Institute, and Mr. Manjula De Silva, Ministry of Health, Postgraduate Institute of Medicine, Health Informatics Society of Sri Lanka, and AHIM for providing me this wonderful opportunity. I think the forum is open for discussion now.
Yes, thank you for that presentation, Dr. Chamika. We now open the question and answer portion to all our participants. So if you have questions or anything you would like to clarify, please feel free to type your questions in the questions box. Thank you. Hello, Dr. Chamika. We have our first
Yeah.
question. It reads, how can the academe contribute to the health insurance efforts in Sri Lanka?
Hello. Yes. Actually, from the postgraduate, actually we have several several types. That's a very good question. We have several sectors contributing for health insurance because, for example, let me get to this slide. Currently, when it comes to healthcare delivery, I'm in the Postgraduate Institute of Medicine, and University of Colombo provides various of IT degrees, which is specifically dealing with the Sri Lanka Insurance Institute, which affiliated because Sri Lanka Insurance Institute is the main academic body which overarches the entire system. So they provide all the examinations, and they maintain the quality and the because all the insurance agents and all the officials in the insurance stream, they have to undergo certain examinations and they have to be very qualified before entering the stream. I hope it answered the question.
Thank you, Dr. Chamika. Our second question is, what software is used by insurances currently, and is it similar to OpenIMIS?
It's like this because currently we have uh, 28 insurance companies. So some of the insurance companies, they still use the manual process like paper-based formats, and most of the other companies, they have in-house development of their own insurance platforms, softwares using their IT development. And the thing is, like, none of these systems are not integrated, but I'm talking about the life insurance. But when you talk about a general insurance, there's a common platform, for example, for motor, fire, and etc. If it checks, there's an entire system which checks if that person has claimed in another insurance company, there are previous claims like that, so it's integrated. But the life insurance, still it's not integrated there. So some companies, they have implemented, and there are few companies which are seeking for um, I mean softwares, insurance management information softwares. And also regarding the state sector as well, NITF also, they are also very much interested in developing. At the moment, they are developing their own software in-house by using their own developers, but they are also pretty much interested in integrated system. I hope it's adequate.
Hello, Dr. Chamika?
Hello? Yeah. Hello?
Hello?
Yeah, sure. Shall I type the answers for the questions or shall I just discuss it?
Hello. Yes, sorry, I lost my audio earlier, Dr. Chamika. Were you
Ah,
able to hear my third question?
no. A third question is what are the possible constraints in implementing the open IMIs in our country? So
Yes.
yeah, actually there are a lot actually. For it, number one is government commitment, which has to be, I mean, tackled politically, and there's always a lack of poor penetration of insurance. I mean, so and also I think I mean because a very limited amount of research has been conducted in this field of health insurance and health financing in Sri Lanka, and I think mainly it's about there should be a government commitment as well, so which can be tackled very strategically.
Yes, thank you, Dr. Chamika. I think Sir
Yes,
Sarav has a question. Sir Sarav, you can speak
yes.
on your microphone.
Hello.
Yes, hello. I think Mr. Sarav got disconnected. So
Okay.
to proceed on the next question, Dr. Chamika, it reads, do you have
Yes.
specialized algorithms for claims review or management that we can learn from and include into OpenIMIS?
At the moment, because it depends. For example, in the private sector and the state sector, for claim reviews, they usually outsource. There are outsourcing companies which do the claim review process. So it includes maybe few medical doctors, but maybe with the further discussion, we could come up with a proper algorithm for case claim review management. So
All right. Our next question is from Mr. Siddharth. Ah, I think Mr. Sarav already reconnected.
yes.
Hello, Sir Sarav. Hello, Sir Sarav. Can you unmute your microphone? Hello. I think he's having problems with his audio. Maybe I can proceed with Mr. Sarav's question. It
Yeah,
reads,
sure.
you mentioned that you have approval for use of OpenIMIS. What would this mean? What kind of insurers are interested in using, and how can we support?
Actually, we initially started as we were trying to get the approval for the pilot project, which includes, which represents entire country. I mean, take samples of insurance agents and to implement the open IMIS. And we could, if we can generate positive results, then we can I mean, we can present it to the ministry of the relevant Ministry of Finance and public administration to with the proposal to absorb that. So I mean, there's a good, I mean, there are a lot of innovation to, I mean, opportunities for integrated all the health, I mean, insurance system, because currently we got the health systems. I mean, they are, I mean, all the what I learned is like all the private health care institutions also, I mean, they are very much interested in utilizing disease patterns and disease patterns and such as morbidity and mortality report data, so they can I mean they can actuate their next year fundings, and they can do the allocations and stuff. So
Yes, thank you, Dr. Chamika. Our next question is from Mr. Siddharth. You mentioned lack of innovative product in the insurance market. What, from your perspective, would be such innovative solutions in a country which relatively positive health figures achieved through supply side funding approach followed in Sri Lanka?
yeah, that's a very good question by Siddharth. It has several aspects. I mean, at the moment, I mean, because this insurance, because at the moment, what happens is the it's a reimbursement based claim the patient claims from the insurance company through the reimbursement process by submitting their original bills and stuff. So it's a very time consuming process, and it's a very energy and energy consuming and very it's not a cost effective at all. But with OpenIMIS, I believe there's a direct because you can do a direct payment for all the private health institutions regarding their bills and after claim reviewing and processing. But some of the few of the insurance companies has already started using their own system, but it's not fully implemented. So it's a very fuzzy area. And as I think, and also, I mean, all the health insurance companies also, they have also developed very innovative solutions, such as, although they have been divided into life insurance and general insurance, they have their investment part in it as well. For example, for life insurance, although they cover the medical aspect, they also have some portion of investment wise that they can build a fund. So they are at the maturity of the the certain age, they get the entire amount. So there are some few insurance companies which are already doing it. So it's need centralized regulation and rolling out of such innovative solutions, which will relatively, achieve a positive health figures in respect of health insurance. I hope it answered your question.
Hello?
Hello. Yeah.
Yes, Dr. Chamika. Our next question is from Dr. Manjula.
Yeah.
It reads, does OpenIMIS extend to the private sector? How much support is shown by the private sector in implementing OpenIMIS?
At the moment, according to the discussions we had with the IASL and the SLII, they are, they are all the CEOs. They are very much interested in implementing OpenIMIS. Actually, the discussions are still, going within the IRCSL. It might take about another 3 weeks to get their final decision. So, according to them, actually, their main problem is health checkups. Because most of the time the life insurance is always down going. investment for them because there are a lot of fake claims and and they have to outsource third-party companies for the the claim review process. So they are very much interested if the OpenIMIS can streamline the health claim review process, and mainly including most of the medical officers in that process. So the idea of, the guidelines and the terms and conditions of implementation would be provided shortly in next few weeks. Actually, I hope this.
Yes, thank you, Dr. Chamika. We have another question. It reads, how can private insurance companies take advantage of OpenIMIS?
Yes, because as I have mentioned earlier, most of the insurance companies, they have their own the insurance management systems, but they are mainly customized for their own environment. But there's no any platform which integrates all of them. So maybe in near future when the digital health ecosystem matures. um Probably implementation of personal health number, master patient index. Probably there might be opportunities for automatically push all the relevant data into the open IMIS with the consensus and with the approval of the Ministry of Health and the relevant data elements. So there's I think the private companies from would take a lot of advantage out of it when it comes to identifying disease patterns, and so they can plan their annual allocations and so on. I hope it's
Great. Thank you, Dr. Chamika. Our next question is, you said claims are outsourced to be processed by external service providers. So how are those claims passed on, digitally or on paper? And if digitally, in which format? Excel or other software?
uh, it depends. Mostly when it comes to the state sector, as I got to know, it's mainly done by paper-based, and also digital means Excel not through a system actually, because they are independent bodies. They just go to the patient and ask about their health status, and they get to an evaluation on person to person, and that's then they report back to the company and make the claim report. That's
Great. Thank you, Dr. Chamika. I'm just checking if there are any more questions from our participants. I think there are no more questions. So I think we can wrap up the session. No question. Right. I think there are no more coming questions, Dr. Chamika. Thank you for joining us and sharing your expertise. Also for our participants for actively participating in this webinar. So if you have any more questions to our speaker, please feel free to contact us at the Secretariat email. And for those who came in late, this session is recorded. It will soon be posted on our website. Thank you, Dr. Chamika, and thank you, everyone.
Thank you. Thank you so much, everyone. Have a great day.
Thank you. Bye.